Begin by welcoming the patient into the MRI suite and guiding them toward the exam table. Assist them in lying comfortably on their back and position their head gently inside the head coil. Provide an emergency call button, clearly explaining how to use it if they feel uneasy at any point. Place ear protection or headphones over their ears, then secure the coil around their head. Align the patient using the glabella as your central landmark, then slowly advance the table into the bore, making sure they remain calm and relaxed before leaving the room. Once you are back in the control area, open the patient browser and select or manually enter the correct demographic details, including accurate body weight, as this ensures proper system calculations. Confirm head first, supine as the body position, and load the protocol requested by your radiologist or hospital guidelines. Start the exam with a 3-plane localizer. Use the sagittal image to plan your axial stack. Slices should run parallel to a line joining the inferior edge of the genu to the splenium of the corpus callosum, covering the entire brain from the vertex down to the foramen magnum. On the coronal localizer, ensure the midline passes through the superior sagittal sinus, third ventricle, and brainstem. Apply the planning and proceed to your axial T2. For additional axial sequences, T1, flare, diffusion, etc., you can copy the geometry from your initial axial plan, but confirm that coverage and centering remain correct. Next, plan your coronal sequence. Using the sagittal localizer, orient slices perpendicular to the genu to splenium line. Coverage should extend from the frontal sinuses to the posterior occipital lobe. Ensure the coronal field of view is centered appropriately. On the axial view, the slices should remain perpendicular to the brain's midline. Now move to your sagittal planning. On the coronal reference, make sure the central slice aligns parallel to the midline of the brain. Cover the entire width from left to right, centering precisely over the midline on the axial view. For diffusion imaging, plan axial slices parallel to the line from the glabella to the foramen magnum. This angle helps reduce susceptibility artifacts near the skull base. Confirm full coverage from vertex to foramen magnum and maintain midline centering. If contrast is requested, verify the patient's kidney status following hospital or national safety policies. For post-contrast imaging, you may reuse the pre-contrast geometry for both axial and coronal T1 sequences. Enter the correct contrast agent and dosage before administration. Inform the patient to remain as still as possible, especially if they need to be slid out briefly for injection. After injecting contrast, confirm they feel comfortable and that there is no sign of extravasation before continuing with post-contrast scans. As sequences acquire, review images routinely. On T2 weighted images, fluid and fat appear bright, and many abnormalities show increased signal. Flare suppresses CSF, allowing clearer visualization of lesions near ventricles or cortical sulci. T1 weighted images show dark fluid and bright fat. Most pathologies appear darker than surrounding tissue. Diffusion sequences provide additional insight. B0 images resemble T2 weighted appearance. Higher B values, for example, B500, B1000, highlight restricted diffusion as bright areas. On the ADC map, restricted diffusion becomes dark. Finally, compare pre-contrast and post-contrast T1 images. Enhancing lesions will appear brighter after contrast injection, and their distribution can be confirmed in axial and coronal planes.